Dr. Rachel Sieke is a psychiatrist who brings a refreshing approach to medicine through her philosophy of curiosity over judgment. She specializes in catatonia, invisible illnesses, including POTS and long COVID, and uses her own lived experience with mysterious health conditions to create safer, more understanding therapeutic relationships. Rachel is passionate about teaching medical students and residents to recognize bias and create patient partnerships rather than adversarial dynamics. Rachel, please tell us more about your work and then ask for what you need and offer what you can.
Thank you so much, Dawn. And you gave a beautiful priming introduction about some of the values that are most important to me. I think I say at least once a day about curiosity and the idea that as we move toward curiosity, we by necessity move away from judgment. It's difficult for those two things to exist together. I want to share a little bit about my personal journey or the salient parts that have built up my professional identity as a physician and how I not only incorporate my values, but how I have found my values. It's sort of the first, I think, developmental event that happened that I look back to is when I was in medical school. I developed a number of health issues that were a bit vague, confusing, and difficult to connect. I got some answers, and some answers I still don't have or found only years later. And this was maybe my first year of medical school, which was sort of an important developmental time where you're at the beginning of that Dunning-Kruger effect, where you start to learn about something and build up your confidence in how much you know it before you realize that you actually don't know anything. And so I really developed a fair amount of health anxiety, and it was a focus for me for about 2 years, a fruitless one. What I discovered was I found some allies in the healthcare field. I found some people who were really dismissive and I made things worse than they were, but it wasn't a universally bad or good experience, but it was unhelpful overall. It didn't lead me to better functioning or relief from symptoms. It really just took up a lot of space. And I eventually came to a place where I decided I'm going to walk away from this. That for me, my health issues were not getting worse. They were fairly stable. They weren't getting better, but I had learned to live with them. So I decided to just turn my attention away. If things changed, I might look back, but I needed that space for other things in my life. And that was so profound, was making that shift. I couldn't tell you exactly how I came to that. But now as a psychiatrist, I do a lot of work trying to help other people make that shift for themselves. Sometimes we need attention on the things that are going on with our health. But sometimes it's really better to shift our attention away or only give it the attention that it needs. The other thing that I look back at as sort of a pivot point in my development in my identity as a physician was in residency when I realized how much bias I had towards patients, specifically who were receiving controlled substances. And came from a good place of being principled, of seeing the harm that that causes. In my first year residency, as many psychiatry residencies do, we had a lot of inpatient experience where you see kind of the worst of addiction and inappropriate prescribing and abuse of medication. And so there was sort of this selective view of what that was and seeing the harm of it that really did not capture the fullness of people's experience. It certainly didn't even capture the experience of the people I was seeing on the inpatient unit. That I made assumptions and often wasn't updating them when people were in distress, insisting that they needed those medications. And I, with some kindness and some authority, but no, it's really not good for you. And even if that was right, that is not how I would look at it, talk about it, or think about it now. There was sort of a specific encounter in my second year of residency where I saw an outpatient who I read her chart and I came into the appointment in my battle gear. I was ready for a fight. She was on benzos and opioids and in her early 60s. I was like, well, this is not going to work. And she was absolutely lovely. She heard all of my arguments and took them seriously and thoughtfully and was on board. And it made me realize, like, wow, I was ready for a fight. And in fact, I didn't find one really was the thing that brought my bias about it into consciousness. that leads me to the next phase, which I will call the psychological safety and authenticity phase of my development. I had some safe spaces to process that experience. I had a good group of co-residents. I felt supported by my program director, and we had weekly meetings. Me and my other co-residents that were facilitated usually by a social worker, where we were encouraged to talk about whatever was on our minds. And I had space in those meetings to talk about the mistakes that I made. And I didn't feel worried about being judged or being retaliated against and getting in trouble because of things that I did. And that was amazing. And I have come to understand that that is actually maybe not all that common to have that experience. Even people who do have similar groups, sometimes there's different drama and group dynamics that make that less of a therapeutic space. But I grew so much from those meetings of feeling safe to be great and safe to be flawed, just to be what I was and wherever I was with developing. And when I left that and I realized that not everywhere is that, then. So I have resolved to bring that with me anywhere that I can. That thing is psychological safety, which we could define as an environment where people feel free to question, to disagree, to speak, stand out, take risks, and fail without fear of retaliation or humiliation or judgment. And those environments are so, so essential. That is where creativity and innovation, connection comes from. And actually, the probably best and most sustainable version of productivity. It is harder work to create that than a culture of sort of fear and efficiency, and it's more fragile. One of the things, if you talk about psychological safety, that I think we need to discuss and you should know is that it is a force that flows downstream. Psychological safety needs to be established by whoever has more authority in the dynamic. And that might not be a person, it might be an entity or an organization. Rarely are relationships on equal footing. Even social relationships have dynamics. One person's extroverted, is a little bit more power, is asks for more. The other person people pleases more. But in healthcare, we have more stratified power disparities. We have a hierarchy, and we have physician-patient relationships, which are by necessity one-sided and have power on our side, and the power does not reside with the patient. There are some good reasons why that exists, but we have to keep that in mind that as providers in the healthcare field, we must be the ones to create psychological safety if we're in a clinical role. And that means not judging and staying curious, because if I'm curious, it invites you to share. If I judge what you say, even in a small way, for a small thing, what that does is tells people, oh, this is not safe. And it can be such a small thing. I think we often aren't even thinking about like that this is an environment that we have to create and we have to actively foster. And we think we do it by default and ignore some of the small ways that we signal to people, you can share, but not everything. And I think we don't understand that we're telling people, here's what I need, here's what you should share. But if we have told them, you are limited in what you should share, some things are not welcome here. It's the human brain, which is designed to monitor and detect threat, will generalize that to nothing is safe to share here. And I am going to filter now everything that I say, and there will be a like framing I'm going to try to pitch to you instead of share with you. So it's so easy to lose, but if you have it, it is the most worthwhile thing. I have one more point I'd like to make about the psychological safety and how it has impacted my journey in my life. This happens on many levels. Like there's institutional psychological safety, which is not only the culture in an organization, but how much does the organization, the system of the organization, feel safe to take risks, to admit fault, to look critically at what they're doing and make changes? Or is there heavy liability and high risk if that's true? And then it happens in a power differential relationship, often with a supervisor to an employee or leadership to general employees in an academic setting, teachers and administrators to students. And then social interpersonal, where we have more equal footing relationships. And the last one is intrapersonal. We actually have a relationship with ourselves, and one that is really essential to build psychological safety. I think that's the one we don't talk about, and probably is the most important one. How safe are you to acknowledge your mistakes and failures, to question and to be unsure about yourself with yourself? I'd imagine probably not that much. It's actually maybe the common human condition that we don't create safety for that. We, in fact, are conditioned and wired to look at the threat of our own behavior and to lean into that. If I see the threat, I'll avoid the threat. And there are some interesting neuroscience reasons why that is actually a terrible strategy. It's much more effective if, for ourselves, we have a culture of, well, that sucks. That wasn't a great decision. That wasn't a good outcome, but I'm doing my best. I'll do better next time. I'll learn from this. And not, I'm the worst. Why do I do this? I have to stop. And I'd like to share how I was aware of this and how I've come to that, because I didn't actually start off on a journey of trying to create psychological safety for myself. I really started off looking at this in my professional world, trying to create safety for my patients and to try to examine myself in the ways that I wasn't creating safety. And as I did that, and I had a safe space that didn't penalize me, I stopped penalizing myself, that those things were just facts. And even though those facts weren't just fine because I looked at them that way, there sometimes are real consequences. There weren't extra consequences from guilt and shame that I imposed on myself. They were just, oh, well, yeah, I do this sometimes, and this is the time that I'm doing it, and this is the outcome of it. So I don't need to be threatened when it comes into my awareness or when somebody else is aware of it and saying it to me. For instance, time management is not my thing. It has gotten much worse over the last few years because of some health issues, but that does create problems in a variety of ways. I try my best to set expectations with people and to problem solve, brainstorm about how that can have less impact or less negative impact, and I can still sort of meet up with people. But sometimes that creates problems, and I don't have to feel threatened by that because I know it's a problem, and this is just the time that is manifesting. That kind of leads me to asking for what I need from the group. And I've thought a lot about this because the one area that I've struggled to establish safety in is in my anticipation of the professional world at large. I can create safety for myself, but like I said before, psychological safety flows downstream. So when I'm in a hierarchy, I still need somebody to establish a safe environment for me to be in, because even if I don't shame myself, the world can still retaliate against me. A job, an employer can. So I could use some help with guidance, mentorship, creative out of the box thinking, or connections and opportunities that somebody is aware of to help me craft a job and find an environment that fits me and my particular needs. I have not talked as much about my identity as a person with disability, but that is part of my identity. And I'm figuring out the best ways to accommodate my life for that. And I'm trying to figure out where is the place where I can offer as much as I can, but also be supported in the ways that I need support. And not just everybody needs support, but I in particular need support that's tailored to me. I also like to share what I have to offer. I uh, have sometimes a unique perspective about suffering, moral injury, the things that we all experience if we are involved in the healthcare system, even if only as a patient. There's no touching this system without being burned a little bit. And I can be a very good confidant or sometimes challenger to help you think about the experience in different ways. I love to talk with people and process moral injury, which again is sort of a ubiquitous experience here. I've become familiar with the personal board of directors idea. I don't know if anybody's been exposed to that, but the idea that we all need sort of a social network that involves a panel of people with some specific different functions. One being we need somebody to challenge us. We need somebody to be a cheerleader, to support and encourage us. We need a connector who helps us to open doors and find opportunities and move forward. And we also need a confidant. And so I'm not a great connector, but I am quite a good challenger and confidant. So if anybody is looking for that particular place in their personal board of directors, I probably can help out with that and fill some of those gaps.